What's going on, guys? This week we're talking elbow and radioulnar joints. So we're talking about the ginglymus. So first off, a couple major things that we need to talk about. One, elbow, just about every single upper extremity movement, not literally, it's just hyperbolic, but a lot of upper extremity movements are going to be using both the radioulnar joint as well as the elbow joint. These two kind of joints are usually grouped together. There's close anatomical relationship there, right? Like it makes sense. The elbow, radioulnar joint, they're right there next to each other. What's unique though here is that elbow joint movements are able to be clearly distinguished away from those that are just radioulnar joints. And radioulnar joints movements are actually going to be able to be distinguished different than those wrist or those hand movements like we talked about in the other videos this week. So there's some weird kind of nuances here. Not super important stuff that I care that you know that much, but yeah. So let's talk primary bones associated with the elbow joint. So first off, let's talk ulna. Ulna is going to be the much larger proximally bone than the radius. So if we look here on the right-hand side, we can see that ulnar head is going to be quite a bit bigger than the radial head up at the proximal side of it. Once we get distally, however, that radius is actually going to be significantly bigger than the ulna. The scapula and the humerus are going to be the kind of points of origin for a lot of muscle groups that are going to span the elbow joint and serve as the more proximal attachment sites that are going to flex and extend the elbow. And then the radial and the the radius and the ulna are going to serve as the distal attachment sites for those same muscles. So the ones that are going to span the elbow joint and provide for elbow flexion extension are going to be inserting on the radius and the ulna. So generally, what we're going to have is we're going to have muscle origins, humerus and scapula, span the elbow, insert on the radius and the ulna. Getting into that radioulnar joint and the bone, a little bit of the nuances of the bones associated with it, our scapula, humerus, and ulna are actually going to serve as the proximal attachment sites for muscles that are going to pronate and supinate the radioulnar joints. And then those distal attachments of the radioulnar joints are going to be largely located on the radius. So it's a little bit different here. It's a little bit nuanced, but it's a little bit easier to remember. So if we're talking radioulnar joint, then we're going to be talking scapula, humerus, and ulna origins, and we're going to be talking distal attachments on the radius. Some pretty big bony features for you guys are going to be the medial condyloid ridge, the olecranon process. So olecranon process is going to be here. Condylar ridge is going to be here. The coronoid process, as well as the radial tuberosity. The coronoid process is going to be here, and then the radial tuberosity is going to be here. Keep moving with those bones. On the other side, we're going to be looking at the medial epicondyle, the lateral epicondyle, and the lateral supracondylar ridge. So we're going to have the medial epicondyle right here. We're going to have the lateral epicondyle out on the outside. We're also going to have the lateral supracondylar ridge. So the lateral supracondylar ridge, there it is, right up here. I was getting backward and forward with what my views were. So talk joints, right? So our elbow is going to be a ginglymus or a hinge type joint. It's largely only going to be allowing flexion and extension, right? So flexion and extension, flexion and extension. There's actually two related joints here. We're going to have a humeroulnar joint as well as our radiohumeral joints. So those are kind of be playing a role in the elbow joint. Right, so the elbow joint is going to be a hinge type or a ginglymus-based joint. You guys should remember that from the charades game that we play in class. It's going to be predominantly responsible for extension and flexion only. It's actually two interrelated joints. So we're going to have a humeroulnar joint as well as a radiohumeral joint. Two different joints are going to be comprising the elbow joint. Predominantly, it's going to be an elbow motion that's going to use articular surfaces of the humerus and the ulna. If we look back at the picture, you can see that the articulation face is going to be between the humerus and the ulna. And that's because the way that ulna kind of fits on the humerus, right? There's actually relatively small amounts of contact between the radius and the humerus, whereas the ulna and the humerus have quite a bit of articulation surface. There's quite a bit of shared surface between the two of them that the humerus and the ulna actually articulate across each other quite a bit more. The major extension endpoint is going to be when the olecranon process is received by the olecranon fossa. So it's kind of like an insertion into this olecranon fossa. So fossa is generally meaning hole, and the olecranon process usually means an outcropping. So what you kind of get when you have this full extension is going to have this olecranon process basically getting into and placed into the olecranon fossa. And when that happens, when you get that placement of the olecranon process inside of the fossa, you're going to have you're going to have quite a bit of an increased amount of stability occurring. However, when that elbow's in full flexion, right, like you're flexing the biceps hard, when that elbow's in full flexion, you're going to have the coronoid process fitting into the coronoid fossa, right? Extension, olecranon process, olecranon fossa. Flexion, coronoid process, coronoid fossa. One thing to think about here is like ole, right? Like you kind of go into extension. I know it's stupid, but you go into extension when you're hitting the ole thing. Think olecranon process, olecranon fossa. And I guess you can kind of think you're flexing when you put on a crown. Corona means crown. Coronoid process, coronoid fossa. I don't know. Come up with something stupid to remember. Something to think about is that as the elbow flexes, so as you go from extension up into flexion, after you get to about 20 degrees or more of flexion, you're going to actually have a little bit of laxity that becomes present. And so you're going to actually unlock the elbow a little bit. So you're going to allow side-to-side articulation, and it won't just be explicitly flexion and extension that's going to be occurring. When you start getting into flexion, the stability of flexion is going to be provided by the radial collateral ligament, which is going to be on the lateral side or on the radial side. And then on the medial side, it's going to be provided by the ulnar collateral ligament. That ulnar collateral ligament is going to be frequently injured. It's going to be damaged. I don't want to say often, but it's a common injury that occurs in throwing activity-based sports. So it's something that you'll see pretty frequently in baseball is UCL injuries or Tommy John's injuries. And you can also see it in contact sports as well, as people will tear their UCL. What used to be basically a death sentence for a pitcher or a death sentence for a baseball player with Tommy John's surgery, with UCL surgery, is now actually gotten a lot better. And what's really interesting is essentially what would happen when you were a baseball player and you had Tommy John's. If you were a good baseball player, it would eliminate you from any potential of the draft. It would eliminate you from the ability to basically go pro because no one was willing to take a risk on you. However, the surgical procedures that have kind of developed in recent year have actually allowed for athletes to continue on. It's created a more stable joint. I actually worked with a pitcher that was drafted by the Yankees a couple of years ago, and he had Tommy John surgery in high school and ended up going through a pretty advanced surgery and then going through some really good rehab and strength and conditioning, and he was still able to get drafted by the Yankees, which is pretty impressive feat, right? Since we're talking injuries, let's talk radial collateral ligament or RCL ligaments. Realistically, it's going to be a lateral stability. It's not injured that frequently. I mean, there's definitely injury types that can occur with the radial collateral ligament. They're just not common. You can have lateral ulnar collateral ligament tears as well. And that's going to be when you have a posterolateral elbow dislocation. So you can actually dislocate the elbow backwards, which is pretty disgusting. And then there's this annular ligament. So it kind of wraps around the radius head right here. This annular collateral ligament. And it kind of helps tie the radius into the ulna. kind of crazy. One of the common ways that this gets injured is called nursemaid's elbow. And what happens is parents will be like holding their kids' hands and like swinging their kids around, and you will actually pull that radius because they're so young. You can actually pull that radial head out of that and have nursemaid's elbow. So you actually pull the radius completely out of the annular ligament. So it's no longer supported, and it's not like a dislocation, but it's kind of like you're no longer in the correct position. It's pretty disgusting. Google it. It's worth a Google, right? So let's think movement degrees. How much movement are you going to possibly have when it comes to elbow flexion and elbow extension? So go ahead, stick your arm out just like we do on all these motions. Hold your arm in full extension. We'll call that 180 degrees, and then flex up. You can easily hit 90 degrees and then continue flexing, and you'll probably only get to about 150 degrees of flexion, right? From 0 to about 150 degrees of flexion. If you got big biceps, you get a little bit less. If you kind of have weak little biceps, like some folks like Ben Nicholson, you might have a little bit more range of motion. But in general, it's about 0 to 150 degrees worth of range of motion. Some folks have about 10 degrees of hyperextension. You always are going to be able to say, oh, look, I can hyperextend my elbow. You can. Some folks can do it more than others. So if we're talking hinge joint and the amount of flexion and extension that can occur at the hinge joint, how when you are going into extension, you've got the olecranon process, olecranon fossa. When you're moving into flexion, you've got the coronoid process, coronoid fossa. Let's move into the radioulnar joint. So the radioulnar joint is going to be a trochoid or a pivot type joint. And what that pivot type joint means is that it is actually able to pivot or rotate. It rotates around the ulna, right? The proximal end of the ulna allows for the radius to actually rotate. And when you look at the structure, you can actually see that there is a pivot point, right? Like it's kind of like screwing in and screwing out, screwing in, screwing out. It actually allows for this high level of rotation to occur. And that's where the annular ligament is going to come into place. And it actually pulls the radial head into the ulna. And that's why you can see if you have nursemaid's elbow, you give a kid nursemaid's elbow by slinging them around the place, which I don't recommend. I don't condone either. You can actually pull that radial head out of the annular ligament and cause some pretty severe trauma. Now, if we're talking radioulnar joint, we're predominantly going to be talking supination, pronation, right? So in radioulnar supination, we're going to be able to supinate about 80 to 90 degrees from neutral. So let's call this neutral, vertical, right? Going to be able to get about 90 degrees of rotation. Now, that's pronation. I'm an idiot. Supination, you're going to be able to get about 80 to 90 degrees. So supinate, palms forward. Pronation, you're going to be able to get about 70 to 90 degrees from neutral, right? So something that I want you guys to think about is how much synergy exists between the glenohumeral, right? So the shoulder joint, the elbow joint, and the radioulnar muscles. How much synergy exists between those joints as well as those muscles? Well, if you think about that, most of the elbow flexors span the shoulder because they have origins on the scapula, and they insert all the way down on the ulna. You're going to naturally have quite a bit of synergy and movement, synergistic movement. A great example of this is to picture what happens as you go through a range of motion. So let's say you're tightening a screw, right? Righty-tighty, lefty-loosey. Let's say you're holding that screwdriver up and you're trying to crank down on that screw. So when you're tightening that screw, what's going to be happening? We're going to be supinating. So we're going to have radioulnar joint action, right? Supination. Everyone see that? We're also going to externally rotate. So because of the position that we're in, we're going to be externally rotating. And then we're also going to be flexion. We're going to have flexion occurring at the glenohumeral joint, right? We're going to have flexion, and we're also going to have flexion at the elbow. So you have supination, flexion, and external rotation. You have a lot going on, but they're all working together, and it's essentially stabilizing all the way up the kinetic chain. If you're loosening that screw, think about what's going to be happening, right? We're going to be pronating we're going to be internally rotating, right? Internal rotation. We're also going to be extending of the elbow and the glenohumeral joints. So in the next video, we're going to get into some of the motions associated with the elbow joint.